absolutely appreciate you coming this evening. For those of you who don't know me, my name's Reese Barnes, and I'm the chair of the Excellence in Health Series, and certainly want to welcome you here on behalf of the School of Health Administration Alumni Association. And we're privileged, I should say, tonight to be partnering with the Blue Nose chapter of the Canadian College of Health Leaders, so definitely an added value for you and ourselves. And it's great to see such a wonderful turnout from both the professional and public community, so thank you very much. You know, in 2008, the School of Health Administration launched the public education forum called Excellence in Health Series. And the series is designed to provide an open canvas for which cutting-edge topics are discussed. You know, we've done healthcare policy and planning, decision-making, law and legislation. And certainly tonight we'll be talking about healthcare ethics. So the Excellence in Health Series features national and international lecturers, each respected for their leadership on a topic of discussion, and that's certainly not unlike our lecturer this evening. Dr. Christy Simpson is an associate professor and head of the Department of Bioethics at Dalhousie University. She is the coordinator for the ethics-based collaborations between the department, Capital Health, and the IWK Health Center, as well as the Nova Scotia Health Ethics Network. Her primary responsibilities include ethics education and capacity building, policy development and review, and support for the clinical and organization ethics consultations. Christy completed her doctorate in philosophy, specializing in bioethics, at the Department of Philosophy at Dalhousie University. Her research interests include rural health ethics, pediatric ethics, organizational ethics, and the role of hope in healthcare. And we're so happy that she's here with us this evening. Please help me welcome Dr. Christy Simpson.
Great, thanks. Thanks. I think with the fans on, you probably can't hear me if I'm not using the mic, right? Okay. I thought I would give it a quick try just in case, but obviously this is better. And part of it is, welcome to the folks that are online. There's a few folks that are viewing this at a distance, so welcome. I don't know where to look for that. But also welcome to all of you, and thank you so much for the invitation to do this talk. As you heard in my introduction, ethics is a word that pops up a lot in terms of what I do, and I'm very pleased to be able to share some of what I think about, some of what I do, and some of what I see in healthcare related to the question of making the right decision. And you notice right is in a different color. It's in quotes, right? How can I make it any different? It's sort of a real question for me from a philosophy, ethics perspective, is to really challenge ourselves to think about what does right mean? What does that look like in healthcare when not easy decisions need to be made? Whether you're the patient, whether you're the family member, whether you're a healthcare provider, a health leader, part of a broader health organization, trying to figure out what the right decision is for any particular patient, for yourself, or for all patients is a big question. And so you'll see in my talk this evening that I'll try and interweave a number of those threads through it. And don't let the philosophy background scare you. This is not a crash course in philosophy theory or anything like that, even though I am going to introduce some of the ways that I think about and try to approach some of these questions with you. So if you don't mind me wandering around and using my hands, that's sort of why I'm not at the podium. Makes it a little bit easier. So in terms of thinking about what I do in healthcare, this picture for me symbolizes a lot of what I'm asked to be involved with and participate in. And that's situations where people are concerned, distressed, unsure about where we're headed and what decisions should we be making. So the question is for some folks, see that little path of water through there? Will I make it there? Is that the best way forward? Is it better to try to hop from piece of ice to piece of ice? What if the wind changes? What if my boat is only made of wood? What if I don't have a life vest? And am I aiming towards the sun? Is the sun coming up? Or is the sun going down? And what does that mean, right? So clearly all of those different kinds of things. And I think for me, a lot of the work that I do and other people in healthcare too is trying to figure out how do we navigate these kinds of waters? And how do we face those really tough questions together? Because I think for most people, trying to look at this and face it alone makes it even more challenging. And so the question is, how do we build relationships? How do we talk with each other? And how do we support each other in trying to think about making the right decision? Sort of in quotes, I can't do with the mic at the same time. So what am I going to do? I'm going to set the context for you. I'm going to talk about 3 different sort of situations just to try and capture some of the range of choices that you might be faced with in healthcare, and partly to give me something to refer back to as I'm talking through some of the issues to sort of say, well, how would it work for this particular patient? It's not about necessarily deciding for each patient what's going to happen, but raising the questions about how we might think about it and how we might approach it. And so in that, of course, this is where philosophy creeps in. There'll be a few definitions. But then I'm also going to frame up a few more questions for you and talk about some ethics concepts that for some of you will be familiar: informed choice, substitute decision making, advanced care planning. Introduce that, but I'm also going to look at it and try and draw upon it what I'm calling a constellation of perspectives. And that'll make more sense when I get there, so just hold that in your head for the moment. So let's look at our 3 patient situations. So we have Gina. Gina was recently diagnosed with severe kidney problems. She's wondering whether making the recommended changes in her diet and her medications will really help. Gina may also need to make some difficult choices in the near future, especially if the diet and medications don't work. Should she start dialysis if her kidneys stop working? Would she consider a kidney transplant if it became necessary? So everything from a change in your diet up to big surgery might be in her future. So then we have Peter. Peter's recovering from a car accident. He suffered many broken bones and other injuries. He's been in rehab for the last 3 months to help him regain the ability to walk and care for himself. Peter and his family are now facing questions about whether he's ready to go home. Is he ready? Is his family ready? And I think you can appreciate it's different if you ask it from Peter's perspective, from his family's perspective, and if you're the healthcare provider and the team that's been working with him. So another way you might ask this is it safe for him to go home? And what community supports are available for him? Is it different if he stays in the city here in Halifax? What if he's heading to another rural part of the province? Does that change how you might think what the right answer is? And then we also have Ruby. Ruby's lived a long life and has been steadily declining over the last few years with dementia. She no longer recognizes anyone and has not talked for the last few months. And she's just been diagnosed with pneumonia. So Ruby's partner now faces the question of whether to treat the pneumonia. And for some of you in the audience, you might have heard of how pneumonia is sometimes described, or has been described historically as the old person's friend. Is it a good way to go, to put it crassly? Is that better? Is that worse than dying with dementia? And what does it mean to be the partner making the decision? So probably that picture with the ice is making a lot of sense, right? Those kinds of questions. So in that, right, and you heard the ethics word a lot, where does ethics come in and how do we think about ethics in connection to some cases like this? Appreciating that the range of decisions and choices in healthcare can be quite broad and quite varied, as I've tried to draw out in some of these cases. So ethics for me is fundamentally about questions about how we should interact with each other and how we should live our lives. So how do we do that in healthcare? What does it mean to live the good life? The beer commercials would tell us one way. But from that ethics perspective and from a healthcare perspective, living life well means how do we treat chronic illness? How do we help you live as well as possible for whatever time you might have? When do we know when it's time to stop? And that's where the questions that are important then too, as I'm framing them up, is that they're resolved at least in part by thinking about our values, about what's important to us. They can't be answered solely by evidence or by the facts. So the fact is Ruby has pneumonia and she has dementia, but it doesn't necessarily tell us whether it's appropriate to give her penicillin or not, or to treat her infection? That comes with sort of the values questions around who was Ruby? Who is Ruby? What's important to her? Did she ever make a comment about what she would like for her end of life? All of those kinds of things, right? And so in that, as I'm talking about values, it's very fair to say, well, what are values? What do you mean by that word? And so here's a simple definition. There are things that we think are important for their own sake. Okay. Does that help? No. I know it doesn't, right? So one of the ways to think about this is playing a card game. What's your trump card? You're having an argument with your partner. And you say, well, it's all about fairness. It's all about being honest. Those words that we use to say you need to pay attention. This is what it means to be in relationship with me. Whether it's a personal relationship, whether it's a healthcare relationship, about trust, about honesty, about respect, dignity. All of those kinds of words that we do use in healthcare a lot are the words that are values. They're things that we think are important. They're things that help us work better together, be in relationship with each other, but they're also the things as communities, as countries, help us work together. And so for us in healthcare and thinking about it, Canadians have said public healthcare is something that's important to us. We value having a healthcare system. We all pay for it, and we all get care. But what care, at what time, where, when, become the challenging questions about how we deliver that public good, how we deliver on the promise of a healthcare system, right, and doing the best that we can. And so when we think about our values, it's interesting to think about, well, where do they come from? And sometimes I only know that one of my key values is at stake is when I start getting angry or I start getting really irritated. And people have said to me, like, why are you vibrating in your seat? Why are you I'm like, because there's something in this. And I realize, for me, fairness is one of my fundamental values. I grew up in a family where things were fair. But what fair means in my family and what that looks like can be very different from other families. We also, I grew up on a dairy farm. So hard work, working as a team. You could only do some stuff on our farm if you did it with my brother, who I didn't always like. We had to work together and we had to do it safely. So how do we do those kinds of things, right? So some of those values, I realized we were just talking about, excuse me, going on vacation this summer. It's hard for me to go on vacation because I think I should be working. I'm like, but it's okay. It's okay not to work sometimes, right? And so you start to see some of those broader life choices indicate to us what's important, right? So on that very personal level, where I grew up, how I grew up, what I've been exposed to throughout my life shape my personal values. But knowing there's a number of healthcare professionals in the room too, and a number of health leaders, there's values that come by being trained to be a health professional. The codes of ethics that you follow have a number of values. The LEADS framework for health leaders talks about particular values and what do we look for in a leader and what's important there. Lead by example, walk the talk, right? Integrity, those kinds of things become important too. So you can see values are steeped through personal, professional aspects, but also our healthcare organizations have mission, vision, and value statements. They have particular values that they said are important to them. And through our cultural aspects too. It can be cultural in the sense of my cultural ethnic background, but also recognizing growing up in Canada, one of the values that tends to be different as we look at ethics work across the world is how we understand independence, making my own choices. And that'll come out in some of what I talk about too. But where we get challenged sometimes is, well, what do you mean you don't want to make your own choice? We're so used to making our own choices. And so steeped in a culture that says more choice is better, then it becomes, well, when this choice is overwhelming? Too much choice. Sometimes makes it even harder to figure out what the right thing is to do, what the right decision is for me or for you. And so in that then, I'm going to ask you to do just a quick values clarification exercise. Ooh, you didn't know there'd be work during the talk, did you? So I'm going to ask you, I'm going to throw up 6. Some of you have seen these before, but I changed the wording slightly. So 6 values I'm going to put up, and I want you to think about what's number 1 off that list and what's number 6. And I want you to do it. I'm going to force you to do it. So try and choose. They may not be the ones that you would put up on the 6, but try and choose what is number 1 and what's number 6. So I'll just get them all up here. So the 6 you have to choose from are being comfortable, being healthy, having self-respect, achieving your goals, having stimulating opportunities, spending time with family and friends. So what's number 1 and what's number 6 for you? Have you got it? Okay, somebody shout out what their number 1 is. Being healthy, self-respect, stimulating opportunities. Okay. Any other ones up at number 1? Time with family and friends. Nobody said being comfortable. That's number 6? Okay, so how many of you put being comfortable as number 6? Oh, fascinating. What did you think being comfortable meant? Life is okay? Life is okay? It's good enough? Okay.
Like this.
It's like this. It's comfortable.
Not necessarily challenging.
Yeah, it's kind of, so it's almost like it's bland in some ways. It's okay. It's not fabulous, but it's not awful, so I'll take it. Yeah, interesting. Because as I was playing with these in the department, some people said, well, what do you mean by comfortable? And someone said, well, it's different if you talk about financially being stable or comfortable, and I think about retirement, versus I'm in the hospital and I have got the worst pain imaginable in my life. All I can think about is being comfortable. Take my pain away. Right? And you've identified another way of thinking about it too. So what comes up from that then is we might use a lot of words to talk about what's important to us, but it doesn't always mean we're saying the same thing to each other. And that's a key one about how I talk with my loved ones, how I talk with my family, and how I talk with my healthcare providers or my health leaders. Because we need to talk about, well, what does that actually look like? What does it mean to you to be comfortable? And it's okay if you're ranking at number 6. I'm not worried about that. But the other one is, what if we said you could combine some of them? Because some people have said having self-respect is part of being healthy, right? They go together. Because if you think of being healthy as being spiritually, mentally, emotionally okay, dignity would be another word that people might use for self-respect. I have dignity. You put that all together, right? So part of what comes out, and let me ask you this before I move on too. How would you rank it if you were 15 years old? Some of you have heard me ask this one. If you were 15, what do you think would be at the top? Yeah, the list changes a little bit, doesn't it? And some people have said, well, if you could separate time with family and friends, then it would be spending time with friends. Absolutely. Get away from my family for a little bit. But you put stimulating opportunities up there, right? And a number of you put it as number 1 already, right? But part of it is, what do we look for in life? What makes our life go well? And is health something that's a value in and of itself that helps me do other things that are important? Or depending on what I'm faced with, I've just been diagnosed with something, health is going to take on a primary value. It's going to be the thing that I'm really thinking about and focusing on so that I can do some of the other stuff. But it's going to shift, right? And that's the other part about values and trying to make the right decision is we need to think about, how do my values change? What I might have said is, well, I want to achieve this in my career in the next 5 years. Here's my career goals. I get a diagnosis of cancer. I might think, you know what? That's not what's most important to me anymore. I want to spend more time with my family and friends. I want to do those other kinds of things too. And so there is a way that sometimes crises in our health or a change in our health can really shape and challenge us, but also shape where the direction that our life takes too. And so we need to think about that and bring that into the decisions we make as well. And that's where, and you've kind of heard me playing at it a little bit already, is what do we mean by the right decision? Here are some possible explanations or ways that we can understand right. It might mean the best decision. I've made the best decision for myself. It might mean it's the best possible decision in this situation. They're not the same thing, are they? So best possible is we don't have the community support, so maybe Peter needs to stay at home. I made the best possible decision about my diet and medication, but oh my goodness, that diet is awful. Who could follow it? That's changed. So I made the best effort. I made the best decision I could, but it was really hard to follow through on the decision. So does that change it? Most appropriate. I'll come back to the appropriateness language in a moment. But some people talk about it, well, it's the most appropriate decision. Great, good on you. Might also be the easiest decision. Think of trying to go out to a restaurant with your friends or your family, and you're like, where are we going to go? Where are we going to go? And it keeps circling and circling. I'm like, okay, somebody just make a decision, and we'll go with it. That's the easiest one. Somebody just take charge and make the decision, whether it's me or somebody else, let's just make it. So sometimes it's the easiest, is the right decision because it's not important enough to me to continue to fight for it, to push for it, or to just, sometimes we just need to get along, right? And we need to go along, right? But when it comes to my healthcare, is that the way I'm going to approach it? Other times we need to recognize sometimes it's really about the least harmful or the least worst. Because we can't always get the best decision. And there are a lot of things in healthcare that happen that are, doesn't matter what decision you make, it's always going to feel like it was an awful place to be. And how do you make a choice out of the least worst options? And having participated in some consultations around, that's how people were framing it. Those are tough ones. And those are ones that still sit with me, even though it wasn't my decision to make. Participating, trying to help, provide some support, have some conversation around how do you figure out what's important when there really is no good option is a big piece of it. But then we might also think about the best decision is the one that's most consistent with standards of practice and policies. So we're doing what the evidence tells us. If it's standards of practice, we sort of have a sense of, well, these are the things that we would recommend. That's the decision I went with. If you're telling me there's a 90% chance of cure if I do this, most people are going to say, okay, that's great. Especially when a lot of what we do in healthcare, it doesn't even get to the 90%. Wonderful. But it might also be about policy saying, here's how we work through these kinds of situations. So the best decision or the right decision is the one where we followed a process. And as long as we have confidence in the process, we can usually have confidence in the outcome. But we need to really build good processes to be able to do that. So whether it's me trying to follow a process around informed consent, which I'll talk about in a moment, or something else, those are some of the key pieces we need to look at. And that's where I wanted to introduce the notion of appropriateness of care a little bit. So it is a concept that's out in the literature. People are starting to talk about it a little bit. But appropriateness of care in a very broad sense, if you're thinking about it in relationship, not to sort of necessarily your one-on-one decisions in healthcare, but sort of about healthcare overall, this becomes an interesting phrase for me to look at. Is, well, who determines what appropriate is? Is it something we do together? Is it something our government decides? Is it something that I have a voice in? And on what basis are we deciding? Do we have evidence that helps guide us? What are the key values that we're using in that? And what do we mean by care? If you think about the care options for Gina, Peter, and Ruby, well, Peter's about care, a different kind of care, rehab care, potentially at home. Gina's looking at, maybe some big surgeries, dialysis, and ongoing kind of intervention. And Ruby, we're not sure where she's located, but she's probably in a long-term care facility or an assisted living facility. What are the implications there? What does that look like? Right? And with that then, I think one of the interesting things that we come to, as much as I talk about, and you'll see me talking about patient and family decisions on that individual basis about what confronts me in terms of healthcare or confronts you in terms of healthcare, there is that broader tension sometimes, I think, about how we make decisions individually for each patient, for each family, and the broader decisions around where are we headed with healthcare overall. And that's what I mean by about the possible tensions from a group or a public perspective. Because we're all invested in having healthcare and having good healthcare. But how do we make some of those broader trade-offs when we know it might mean, for some patients, it's about the best possible care, the least worst, least harmful? And how do we talk about those kinds of issues with each other? Big downer, isn't it? So let's get to some of the things that we can start to look at in terms of how do we begin to sort of approach and pick away at figuring out how do we make the right decision. And this is where I want to talk about it from a constellation of perspectives. I am going to talk for the next little while about more the patient and family member perspective. How do you start to make decisions? How do you get the information that you need? What does that look like? But also keeping in the back of our heads is around what's the healthcare provider role in that, health leaders and health organizations, as well as the health system and the community and the public, because they're all part of constructing and shaping what options we have to choose from, if we have options to choose from, and how we make the right decision based on what's available to us. So starting with the patient, right? We come back to what's the right decision for me? But I might also frame it as what's the right decision for my family? Because part of that is recognizing, as much as I might be talking about me as a person making my own decisions, the reality is I'm embedded in all sorts of kinds of relationships that may or may not filter into the decision making that I have, right, in that process. And so part of it is also recognizing then, so for me, for my family, for the people that I care about, is that sometimes with decisions we often frame it as, well, we just need to make a decision, it's cut and dried, done. Are decisions ever really like that? You make a decision, the path goes this way, but there's always the later that comes after the decision. Okay, well, I made a decision to start chemo. Gina might say, okay, well, I'm going to start dialysis when that moment comes. But she might change her mind when she actually gets on dialysis. Dialysis might not go well for her. She might say, no, this isn't the choice for me anymore. I'm going to make a different one. So the not now and later makes a big difference, and the repercussions or the implications of making some decisions in healthcare are huge. So do we treat Ruby? Does Peter go home? As well then, as I've already introduced and talked about, is as much as we are interested in the outcome, does it make a difference? Does it help somebody live better for the short term, for the longer term? Do they feel more healthy? Are they comfortable? I'd sneak that in. Then it's also about the process. So how did I make the decision? And sometimes people have said to me, as long as I felt like I made the best decision I could because I thought about everything, then it makes it easier to live with it afterwards. It's the knee-jerk decisions that are sometimes hard for me to live with because I didn't think it through, or I didn't think through what it would mean for my family. And so the reality is there are big decisions sometimes in healthcare that are urgent, and we need to make those decisions quickly. But there's other times where we have a bit of space to kind of think it through. And so in that, and sort of taking the broader piece is, this is where informed consent or informed choice is one of the things that we want to talk about. But what does that process actually look like? Because it can be a process that leads to a decision. It's not necessarily about, okay, I've told you everything, make a decision right now. So in ethics, we often talk about informed choice as being a foundational concept. It's one of the things that undergirds and sort of stems from respect. So how do we demonstrate respect for individuals, respect for persons? And the respect for autonomy piece up there is the ability for me to make my own decisions. We talk about autonomy literally means self-governance. So my ability to make my own choices. And that's particularly in a Canadian and in an American healthcare context, choice is big. We really reinforce and often go back to, well, what does the patient want? And if the patient can't speak for themselves, I'll talk about that in a moment too from a substitute decision-making perspective. But this is one of the key things. And so if it's so important to us, then how does it actually happen? What does it look like? What are the pieces of it? And so here are some of the key elements that are talked about. People might write them in slightly different ways, but they usually include all of these elements in one way or another. So one is, do I have the ability to decide? Do I have the capacity? Healthcare providers spend a lot of time trying to figure out, in particular situations, do you actually have the ability to make this decision? If you're under a tremendous amount of pain, are you able to make a decision? If you have dementia, if it's early stage, you might be able to make some decisions, maybe all of them. As it advances, you might not be able to make some decisions and then no decisions for your own health care. Peter being in a car accident, we don't know what happened to him. Maybe he had a head injury. Does that affect his ability to make a decision or not? So figuring out if you have capacity is one of those big things about, well, do I make the decision or does somebody else? And if you've decided that I have capacity and it's able for me to make the decision, then we're into, well, what information do I need to be able to make that decision? What does that look like? So have you told me, as a healthcare provider, have you told me what I need to know? What do I need to tell you to help figure out how we work our way through, if there's a few different options, figuring out which one is the best one for me? Is the information making sense? I've certainly had the occasion in healthcare sometimes where I'm like, okay, I think I have the capacity to make this decision, but I have no idea what you're talking about. The jargon, the technical language, right? So that sort of sense of saying, okay, can you slow down? Can you tell me that again? Is there a picture? Some of those kinds of things. Is there a website I can go and look at it that you would recommend? Lots of information out on the internet. Not all of it is helpful. And not all of it is useful for the particular thing that I need help with. So sometimes our healthcare providers have been really great at identifying, here are the websites that are really helpful. Here are the ones to get some more information from. But we often forget to talk about voluntariness. So am I free to make the choice? Another way to phrase it is, am I feeling pressured to make one decision or the other? Recognizing we're all going to feel different pressures about decisions, but if I'm making the decision because I think my healthcare provider won't care for me anymore if I say no, or I want something different, that's something we need to look at. If Peter says, well, I can't go home because my wife has said, I'll leave if you come home, he's not really free to make a certain decision, is he? So there's different options in healthcare to think about how do we support people who are not feeling free or able to make some decisions, and whether that's through social work, if it was Peter's case and his wife said that, or also thinking about, well, it is okay to get a second opinion. It is not something that a healthcare provider can threaten me to make a certain decision. Or maybe it's my family that are saying, please, please make a different decision. And how we negotiate those things is really quite important in terms of being able to make that right decision for me. Understanding that I'm embedded within my family and my relationships. And then it becomes that, what is my decision? And so then we see with what I'm trying to get at is a concept of shared decision making, in a sense of how do we bring together sort of the patient who's an expert on your own life. We don't often frame it that way, but you are. You know yourself better than anybody, hopefully. Or with my partner can help draw that out too. So who's the support person for me is then it's also my healthcare provider is bringing their expertise and experience to it as well. So that's the training, the information, the experience that you have to say, well, here's what I know about this range of options. If there are a range, I'm suggesting there might be a few, but sometimes there's only one. So we need to talk about the one versus if you have a few different options that you might go forward with. And so the question is, how do we bring together that expertise on both sides? And hopefully that's what we mean by shared decision making, where it's a sense of back and forth. And I know you probably can't see it totally well with the light, right? Is there a way we could maybe change that because the light's coming? Sorry. Thanks. So in that shared decision making piece is how do we use what you're an expert on, sort of what's important to you, to make that connection to what are the treatment options? Because treatment options are sort of population based. Here's what the evidence is telling us about a mass or a number of patients. but here's how we might translate it to make sense for you. Here are the benefits and harms and how they make a difference in your own life. And that translation piece is really quite key. So that's one of the pieces that I think can help us move towards. Yeah, thanks. Is that better for folks? Yeah, okay. Thank you very much. Yeah. So that's one of the ways in which I think we can get closer then to making the right decisions, is by having that blending or having that connection between what's important to me, what's important to you, and what do you know as a healthcare provider, and how does that connect together. And knowing how that can happen in healthcare, it's amazing to see, right? And I think it happens every day, and we don't often appreciate how valuable that interchange can be and how that connection to be, to feel like I'm not alone making a decision, but there's somebody who I can bounce things off of who has that expertise that I can ask about. But it also then becomes, well, what's my role as a family member? So if the patient's, do I accompany my patient, my family member, or my loved one? I might move between those words. Thinking about what's the right decision for my family member and what's the right decision for me as a family member is something that we need to think about a little bit distinctly. We need to keep separate, because sometimes there's that pressure piece, right? Or sort of what's my role here? And there's two different roles. There's lots of different roles for family members, of course, but two that I'm going to talk about is what's your role as a supporter or a caregiver? To be the person who accompanies to go to all of the appointments maybe, or to talk things through and help to figure out what is the right decision, where you can say, why are you thinking that way? Like, you've never made a decision that way before. What's changed? What's going on? Or you're not talking about this at all. I'm worried, right? And so recognizing what a family member might need as support and looking at and what support they can offer to their loved one who's making a decision can be distinct. But also the one is sometimes you're asked to be the substitute decision maker. So remember when I said about capacity being the key thing about whether I make decisions? If I don't have capacity, somebody else is going to make those decisions for me, and it will often be a family member or my partner. So that's Ruby's partner in that third case who's going to be making that decision for her. So the question then becomes, well, how am I supposed to make the decision for somebody else? And this is where it's actually stated in our legislation in Nova Scotia, but also sort of framed up in a way to try and get us as close to what that person would have wanted. So one is, first we talk about, well, what do I know about my loved one in terms of have they stated any wishes? Have they written it down? Personal directive, living will. Talk about that in a sec. Those are some of the words. So have they written any of that down? Have they said, when we talked about somebody else who was in a car accident, you know, above all else, I want to be home. Being home is where I'm the most comfortable. That's where I feel part of things. So we know that's a wish of that person. That's something that we need to take into account in terms of making healthcare decisions for them. If they haven't stated anything directly, sort of verbally or written it down, then it becomes, well, based on what I know about them, what would they want? So if you're facing a treatment decision, so say Gina wasn't able to make her own decision about organ transplant, you'd say, well, you know, Gina, she was a fighter. She loved to take risks. She would take, you know, she's the one that always drove fast on the road. Don't endorse that. But she's the one that would always be out there pushing the limits. So I think maybe we should give her a shot at this. She would probably choose that if she was here, would be a way to frame that. But then sometimes we're faced with decisions where you go, I really have no idea. They haven't said anything directly about this kind of situation. I know them really well, but I don't know what they would say about whether they would want an organ transplant, or what about the pneumonia decision. I don't know. Then we're into sort of thinking about what's in the best interest of my loved one. And best interest here usually means what is the balance of benefits and harms? If there's a choice I can make that would help them regain their ability to make their own decisions, I should be looking at that one. But it's often about how do I make that balance between what's the best thing I can choose for them. And as saying they're lexically ordered is in that way that I've described it, is that's the list we go through. So you don't start at the best interest at the bottom, you start with, have they stated any wishes specifically or directly? And in that then, I want to acknowledge firmly, some of these decisions are incredibly hard as myself making the decision. I think for family members being in that substitute decision-making role, it can be even harder. Because now I am making a decision that maybe means that they won't be here anymore, right? In those kinds of ways, that it's a very emotional, and it can be a very big ask for family members. And so sometimes I think in healthcare we need to take a closer look at what are the sources of support for people who are making substitute decisions. How do we help them through that? Do we talk them through how to make a decision that's about how would you make the decision if you were that person versus here's the decision I want to make? I can't bear the thought of not having my mom around. Well, that's about me. It's not about what would my mom want if she could say it herself. How do I play both of those roles? Recognizing I'm still going to lose my mom maybe at the end of the day. So that source of support and that guidance, I think, is something that we can offer in healthcare, and we do often have supports that are available, but I encourage, if you're the family member, ask for support if you need it. But also, I think on the healthcare provider side, we can sometimes pay a little more attention to what we're really asking people to do and how we share that decision making with them, and talk them through it, I guess, in terms of that way. The other source of support, is it okay if I take a little? Yeah, okay. The other source of support, I think, is I'm going to encourage you to talk amongst yourselves. Go forth tonight from this talk and talk about what would you like to happen for yourself in a variety of different scenarios. This is something that, and I say that saying go forth and chat and talk, knowing that even in my own family, I do ethics work. My brother's a family doc who works emerge in palliative care. Do you think these conversations are easy for us around the dinner table? Right, so I say it also reminding myself that I need to talk to my parents about these things too, because they need to know what's important to me, as well as I need to know what's important to them. And yes, I'm blessed in the fact that we have good relationships, and I think I know them really well, but it'd be really nice if we had some of the conversations before I actually had to make that decision, if I'm in that role. And so recognizing how challenging it can be to talk about, sometimes it's thinking about, well, what's important to me? So that clarifying my wishes, my values, my hopes for the future. And then once I've got a sense of that, or as I'm starting to do it, or questions come up, is how do I talk about it with my family? Talk about it with my doctor maybe, with other healthcare providers. It's my friends, if my friends are going to be involved. Maybe talk to my lawyer about it. Just so that there's that circle of people who maybe have an understanding of what's important to you, because that information can be so valuable when everybody's going, I don't know. And we have had some cases where people have talked a lot to their family physician, and so if you're able to get the access to the family physician, the family doc goes, oh yes, we've talked about these scenarios, let me tell you what I know of that patient. It makes a huge difference for that family member who's trying to make that, do I treat the pneumonia or not, kind of decision. And then you might want to consider, if you're having the discussion, fundamentally I'm all about the discussion. Think about what's important to you, but also talk about it, that you may want to complete a personal directive. So that's the language that we use now in Nova Scotia. We have new legislation around that. People might have heard of advanced directives or living wills. So there's lots of different names these documents go by. They can be more formal, they can be less formal. But generally they might include something like about naming, if you want to, who's going to make the decision. So I know some folks where they have very fractured families, or families that have very different religious beliefs. They've said, this is who I want to make the decision for me because we share the same belief system. And so it's clear to the family, this is who is going to make the decision. Other family members can be involved, but this is the one who'll make the decision for me. That might be a place where you want to write that down and communicate it. Let that person know that you've written it down too. That's really nice of you. Also, you might be wanting to describe, depending on what's important to you, what decisions should be made for you or how to make those decisions. So some people have said, some patients that have lung disease, and they've had the experience of having pneumonia and been in hospital and being sort of all high-level care, after they've done that a few times, they say, I don't want that anymore. So they will be very clear and write that out and say, I don't want to go to the ICU. If I'm in one of those crises, please just give me palliative care. Let's make that very clear. And so the instruction is very clear. And so sometimes they're called, people will hear about instruction directives. That's what that means. So you can think about, if you're going to do a personal directive and take that step of writing something down, you can think about doing one aspect or both. So I might name somebody, I might write the instructions, or I might put both of them down in a document. And I think the neat part in Nova Scotia now that we have personal directives is that you can also think about not just healthcare decisions, but personal care decisions. And by that it means, who would I like to hang out with? Who are my friends? What kind of social activities? What kind of food do I like? Some of those kinds of things. And I've been joking with folks that if I'm going to write something down, I am not a morning person. And I think if I go to a long-term care facility, sometimes they're not always built around late risers. They're built around people early rising, let's get going, let's do those things. I'm like, please. It'll go much better for me and much better for the people who are trying to provide care to me if I could sleep in once in a while, right? And you think, why would you bother to write that down? I'm like, but that's important. That's something about me. Unless something changes, so I become a morning person, I keep trying. Despite growing up on a farm, I'm not a morning person. It makes light of something that's so serious, but that's one of the ways to get into the conversation. How do I start talking about what's important to me? Well, I realized one day, sleeping in is a big deal to me. I don't mind working late. I don't mind doing that, and not being forced to get up early, I think, is the other part. Right? So one of those things, to sort of think about the range of kinds of things that might be important to you. So some of the questions you might think, what's important? What am I hoping for? The other way to think about it is what I'm most worried about. What am I most afraid of? Because hope and fear are sort of opposites. They go together in that way. So if you know what you're most afraid of, maybe being in pain, being a burden, people often talk about, you can then identify, well, you're hoping for certain kinds of things. You might also think, well, should I ask more questions? Do I really know enough about this to make any kind of decision or directive for myself? Who should I talk with? Who might help me sort of sort those things through? And in that, I think there's two key challenges that are important to take a look at. One is that we typically don't discuss these issues. And if we do, it's often on the basis of misinformation or limited understandings. So as much as I'm encouraging you to talk, I'm also encouraging you to ask, to get more information, to find out what life is like in different kinds of ways. And I was reminded while I was doing this talk, Bonnie Sher-Klein is a Canadian filmmaker, suffered a severe stroke and has recovered from it and has made another film that's called Shameless, The Art of Disability. So it tracks 5 different people, 5 Canadians. It's a National Film Board movie. It's fabulous. And it gives you insight into disability that we don't often have because you get to see them in their homes, right? And sort of, and the way that they joke about some things that you think, oh, I didn't know they would joke about that, right? So for me, it was a fabulous way to start to think differently about what life might be like if it changed as a result of a car accident, for example, like Peter's life. So I encourage you to both get information and talk about it. But I think the other piece, and this is where, as I move into wrapping up, is this other phrase is, well, we're here to help, we're here to care, we're here to do something. Does that sound familiar for the healthcare providers in the audience? We're here to do something. We want to care. And I'm not putting it up as a challenge. Don't get me wrong on this one. The motivation to care, the motivation to do something is valuable and important, and that's what our healthcare system really is about. But I think the do something sometimes is the part where we kind of think, well, what does care look like? Doing something means big. Doing something means a high-level intervention. It means doing more. And not always thinking about, well, sometimes the best care we can offer is, I'll hold your hand. I'll sit here at the bedside. I'll take a moment to acknowledge you're trying to tuck yourself back in after rounds. Everybody's been looking at your sutures, but nobody put your bed sheets back. So that's a moment to provide dignity for somebody, but also to provide care in those kinds of ways, right? And so the doing something doesn't always have to be big, but part of the reason I think it's a challenge for us is because of something that came up in this article that I was looking at that's talking about the difficulty of saying no to potentially life-extending or life-sustaining interventions. We're definitely in a time where it's hard to say it's okay to stop. So it's hard for Gina maybe to say, dialysis isn't for me, organ transplant isn't for me. Yeah, it might continue my life, but that's not the life that I want, right? I want to make the most of a particular amount of time that I have. And in this article, as they're talking about sort of this difficulty of saying no, they identify a few things that I think it's helpful just to talk about a little bit. So one is that they talk about the ways in which routine medical care can tend to override choice. So how many of you have had the experience of talking to somebody or hearing it where they say, I'm in visiting Granny and they came in and they wheeled her off for another test, and I asked Granny why she was going for the test, and she's like, I don't know. That's just what they do. I'm in the hospital. I never know when they're coming, but I get whisked off. Yep. Why are we doing your blood test every day? I don't know. It's just what they do. So some of that, I think, goes back to, are we thinking about informed choices and how all of those pieces? But there's an awful lot of tests that we can do now to try and find out what else is going on. Are those tests actually helpful? Especially if they're painful. And even pinpricks can be painful after a little while. If they're painful, if they're invasive, if they carry risks of their own, are we doing them because there's a reason why? So is it because you might choose a treatment down the road, that having that information will help you sort something out? Or is it sort of, this is what we do? So I think that question of this is what we do, or this is what I expect when I go in the hospital, things will just happen to me, is also a place to sort of say, well, what's going on? So there is a choice about some of those things, or there's an opportunity to ask why. What's going on? Where are we headed? What are the goals of care? Sometimes is the conversation. But I think what they also identify too is that there's been a transformation of the technological imperative into a moral imperative. Now that sounds very philosophy-like, doesn't it? What they're saying here is, as we continue to develop new technologies and new interventions, there's always that sense of, well, we have them, let's use them. That's the technological imperative, is we think genetics now will be the new frontier, all the genetic interventions, all of these things. And yes, they can make a difference. Yes, they can be helpful. The question is, should we always be using them? Should the default to be always to do something and to do the next? And that's where, when they say it turns into a moral imperative, it starts to become not only let's have it, let's use it. It becomes you must use it, you should use it. You're a bad person if you don't. Now, nobody's going to say it that way, but there is sort of this feeling sometimes if we don't try the next thing, or I don't agree to it, am I being a bad patient? Am I being a difficult person? They're offering it to me, so I should do it, right? Not necessarily, right? And so I think both on the healthcare provider, health leader, health organization side, we need to think about this motivation to do something and to think differently about what care is that we can offer. But also on the patient and family side, to be able to expand that space sometimes to talk about it is okay to stop. And putting that out there and saying, what would it feel like to stop? To say no to the next thing. Sometimes it's a relief to put it on the table for people to talk about. It doesn't always mean that they don't say no. They might continue on, but at least they've had the opportunity to take a look at it and to realize their values might say something different. And then there's also the linking of hope with the normal and the routine, use of potentially life-sustaining interventions. So this is interesting for me, as you heard in my introduction. Hope is something that I'm really quite interested in healthcare. And so what they mean here is, the more that we use the technology and use all those interventions, the more it just becomes that's the normal thing to do. Well, we just carry on and we do this and we do this. And our hope, it gets linked to that. So the hope for cure, the hope to make a difference in somebody's life, a good difference, then gets tied to all of those things rather than thinking necessarily about what the quality of life is. So what's my hope for a good life? Even if it's a short life. What's my hope there? How do I say no and say it's actually now a hope for a good death? Right? So the more my hope gets linked to all of those technology things, the harder it is to make a shift or to question, is this the right decision for me? And I think in doing that and doing some research with a nephrologist, this picture kind of captures some of it for me. That we were interested in and there's a reason why I use the kidney case, is with the nephrologist who was looking at patients with severe kidney disease. They were actually going to be going on dialysis, or the option of dialysis. Probably within about a month, they were kind of out of options other than dialysis. And she said, you would think this is pretty serious. This is a big life change. Yes, there's dialysis, but not everybody does well on dialysis. But they don't seem to want to talk about the advanced care planning piece. They don't seem to want to do those things. And so she was really curious about why. And she thought maybe it has a connection with hope. Are they afraid to think about not doing dialysis? Is that what it is? And so are you alone kind of with this light, and is it things looking good or things looking bad? Are you kind of on that precipice of is it okay to move forward or is it not? And interestingly, what those patients told us is they said, well, yeah, I know I'm going on dialysis, but it's a life-extending intervention. It's a life-sustaining treatment. So what's the problem? Of course I would choose the life-sustaining treatment. And they also said with that, I'm waiting for my doctor to tell me that it's serious. And serious enough to talk about advanced care kinds of issues. So the connections between my kidneys are gone, I need dialysis to continue my life, and that I could die, weren't being made. And interestingly, they all said, well, yeah, some of them said, I would like to ask my doctor about some of these issues, but it's really up to her to start the conversation. Like, I don't want to challenge my physician if she's not telling me it's serious, because we only talk about what's happening today and what my diet is and what my medications are. We don't talk about the future. And we talk about dialysis as that'll be the next step. So that's what I do. So you can kind of see in those conversations, so I go back. In those conversations, almost all of these things were going on. That hope was connected to, well, it's a life-sustaining treatment, of course. And, well, the medical care was routine. The medical care that they were getting wasn't signaling to them that this is a big deal. And so out of this, the neat part is she's completely transformed how they talk about advanced care planning and where they introduce it. And so now with the visits, they talk about what's happening with you today and what do you think might happen to you in the future. So it's both. It's not sacrifice one for the other, it's doing both. And she said it's really opened up a whole interesting conversation. A number of patients are still choosing to go on dialysis, but there's a much stronger sense from the patients who choose it, from the family members, and from the team that they're much more confident that they've made the right decision about it, the right decision for them. And so that brings me back to then that question of appropriateness of care. Because I see in that interchange and in that research this connection between how do we bring together the expertise and the options and the experiences that we have in healthcare together with what's important to people. About how do we signal what's important, or this is an important time to talk about big issues, and connect those ones together at the individual level, but also at the health system level, so that there's a need to balance what's right for the individual with what's right for the health system for all of us. And the more we can make those connections, I think the better able we are and the better flexibility we'll have within the health system to be able to balance out what each of us might need. Not necessarily what we want all the time, but what we might need as part of that decision. And we can start to build processes to engage around the values, around the facts and the evidence, because I think it's all of those things, in an effort to make better decisions individually and together, and at that program, organizational, and provincial levels. Because I think ultimately it's sort of that appropriateness of care piece at the broader conversation that helps us do better at that individual interface about making the right decision for me and the right decision for you and for all of us in that kind of way. And fundamentally, I think the more we can do it together, the better it is in that kind of sense. And so I encourage you to take some of the opportunities to engage. So go home and talk to your loved ones. Start some of those conversations. That's fabulous. But also there might be opportunities to engage with your health system, with your healthcare organizations, to start talking about what's important to you and the types of decisions that they're making. And so I encourage you to look for some of those. I know the community health boards have a survey out about health in your community and what's important to you in that way, it's a great place to encourage your voice and start saying, well, these are the things that are important to me. How do we begin to approach some of these issues for all of us, but still retain that sense of what's key for me? And so in that sense, then, hopefully it'll help us move forward together. And that's where I'll end my talk and take questions. Thank you. Yeah. So, do you want to? I can go up there if you want to take the other mic. Yep.
I can be specific because we're treating over here ethic in healthcare.
Mm-hmm.
Now, it doesn't matter what professional I am, but this is what caught my attention. When you talk, you didn't mention nothing about ethic. You mentioned about things, what to do, what not to do, what here. In my opinion,
Mm-hmm.
the ethic stands for not to harm the patient. That's number one. Number two, when the patient comes to you,
Yep.
you want to find out someone that trusts, someone that will tell him the truth. Here, left or right, what will happen, what won't happen. And unfortunately, in the health system today, you don't find it. If it's on the mental health, the only thing what they're going to do is they're going to inject medication to the patient and let them go around to their own business. Hey, you sedated, you quiet, everything's fine. When they make mistake, that's what for me is ethic.
Mm-hmm.
What happened then? Okay, and I will tell you exactly on one occasion. Now, I have some people that when they have some illnesses and they get some medication from the doctors, they're going to look on the computer and they're going to do a essay work that a student at university doesn't do it, with pages, all the side effect and everything. And they won't hear it from over there.
Mm-hmm.
Okay, now, there's one question I want to know. What happened to a cancer patient that had a surgery, an open surgery? What are the rules? Do they have to clean up everything or only one part?
Yeah, I was going to say, you've packed a lot into your comment. And I think,
Yeah, no, because
Yep.
for me,
Yep.
ethic is ethic.
Yep.
When I have a patient that comes to me,
Yeah.
okay,
Yeah.
I tell him in a language that he will understand.
Mhm.
And if it's something that he doesn't understand, I make sure that I will talk to him in a language that he will understand. And he's son of everything that I tell him and everything. So it won't be anything. And if sometime I see that something is wrong, I send it to a second opinion and third opinion. I say, this is my opinion. And I stick to it.
Yep.
So, again, my question is
Yep.
to know how to
Yep.
do why.
Yep.
It's very important to read this one.
Yep.
And I can sit for this.
Yep.
They did a cancer operation to someone and
Mhm.
they didn't clean it up completely. And
Yep.
when you open, as far as I know, when oxygen go in, everything spread. So after the surgeries, they didn't even give her any chemo, didn't give her any radiation. Now it came back 4 years past then, and you should see the family.
Mhm.
Now, forget about the life that
Yep.
she wanted.
Yep.
She wanted to live, she wanted to die, she wanted to do this, she wanted to do that. What happened to the family?
Mhm.
That's, to me, is the ethic thing.
Yep. Yeah, no, and I think, in a lot of ways, we don't disagree about what the things that you've named as fundamental ethics aspects, right, that are part of healthcare. So you named trust, you talked about doing consent well in terms of having the conversation, following it through, making sure you can explain it to patients in a way that they understand. Absolutely, right? We don't disagree about any of that at all. I think for me, in the sense of where you started your comments around sort of the ethics piece, I think I'm still talking, from my perspective, I'm still talking about ethics if I'm focused on values, if I'm focused on processes and those kinds of things, because to me that's all part of how we move towards making the right decisions. But where you ended your comments around I can't speak to specifics of some cases in that kind of way, but certainly, do we get everything right in healthcare in the sense of, do we make mistakes sometimes? Yeah, absolutely, right? Are there adverse, as we talk about it as medical error or adverse event? Yes. And I think one of the things that I've really appreciated sort of being, sort of, if you will, 10 years sort of engaged with healthcare around questions of adverse events or medical errors is that I'm really seeing a strong shift towards disclosure, about talking about it. So it doesn't always happen well in every case, and that's a fair comment. But I think overall I'm seeing a shift from, oh my goodness, let's hide it, let's protect, to what happened, why did it happen, how do we talk to the patient about it, how do we talk to the family about it, and you're right that we need to pay attention to the family in this kind of process. But then also I think I see healthcare organizations taking on the larger issue, which is also, when is the mistake big enough or serious enough that we need to tell the public about it, that we need to talk those things through. So we've had a number of different kinds of, if you will, things come up in Canada over the last number of years around breast cancer testing and some of those things in Newfoundland, for example, where I think we're recognizing for people to be able to have trust in the health system, they also need to know that we're going to be honest about when it's not working well. In a weird kind of way, because sometimes we say, well, if we admit all of our mistakes, people are going to trust us less. And I think what the data shows and what the evidence shows, and certainly what I would argue from an ethics perspective, is the more honest we are and the more upfront we are, the better it usually goes, in the sense of people feel heard, people feel respected in that you thought enough of me to tell me what had happened. I'm not kept in the dark, I don't find out in a secret kind of way, and so that would be sort of where my head would go around the example that you were raising at the end. Yeah. So maybe there's another question. We can always talk more after too. Yeah. Yeah.
How would you handle a situation where, let's say it's a family decision maker having to make a choice for the loved one who is incapacitated and facing death or whatever, and the family member would know full well what the individual's wishes were because they'd made it clear, whether it was about, I don't want to be an organ donor or I don't want to be kept on life support, but the family member is opposed to that view. How do you help that person through that?
Yep. Yeah. They're not unusual that kind of scenario might come up, in the sense of, as families change, as people develop different beliefs and have different experiences, there very well might be, well, I believe this and you believe that, and now I have to make the decision for you. And I think a lot of those ones are really where we go back to saying, well, there's sort of two options really. One is having the conversation about how you're supposed to make that decision. So it becomes that question of, can you set aside enough of your own personal beliefs to follow the wishes of your loved one, of your family member? Because if they've made it clear, then there's actually probably the healthcare team is advocating for that patient as well and having their wishes respected. And so that can open up the conversation around, okay, this is one of those ones where you say it's not about you and being right in your own beliefs. This is about how do you, and different families use different language around it, but sometimes it's how do you honor the wishes of your loved one? And that's where we need to go with this. Usually that works. It doesn't mean it happens quickly, but usually you can get that to come together so that that person will make the decision. Or if they're not able to make it, there is built into the legislation, and it would be expected, if you can't actually make the decision, you may need to step aside. So in the legislation, we have a hierarchy of decision makers. So if I don't name anybody, then there's a list that it goes to about who's going to be there. So, and it does say if somebody can't fulfill that role, then it goes to the next person on the list. So hopefully you would have somebody in that role that could be able to do it. But I would say most of the time the attention and focus is on how do we support that family member in their struggle, if you will, around those ones, but also to make it clear there is an expectation about where you should be focused and the kinds of decisions or how you need to be making some of those decisions. Yeah, so does that kind of get at it? Yeah. Yeah. Yeah.
I guess I had a, sorry,
Yeah.
usually loud voice. I had a couple personal
Mhm.
experiences over the last couple of years with
Yeah.
elderly parents, and
Yep.
I looked at it being a healthcare provider myself and nursing for many years. My dad had advanced dementia and came to the tipping point where we had to have the ambulance come and take him. So my mom was very, confident, and the paramedic came over, knocked on the window, and said, "Do you have an advance directive for your dad? And if anything happens on the way to the hospital, do you want us to start his heart again?" Everyone looked at me like, "You're kidding. They're asking us this question." And
Yeah.
we had a very similar experience in the emergency department with her
Yeah.
2 weeks later
Yeah.
when she was very ill. And it was like the clipboard and they're done. I asked you that question, and I remember Mom looking and
Yeah.
saying, "Are you talking about me? And yes, I'd like you to try if you can fix me quickly."
Yeah.
That kind of
Yep.
thing.
Yep.
So, and then as we moved on in
Yeah.
care, in restorative care, and I actually had a chance to talk to the physicians
Mhm.
about this, is she was a very competent individual
Yep.
by their definition and mine as well. But it was always treating her as the patient
Yeah.
when her dependency was very much on her family. And so, I said to them, it's about a dialogue. You want us to have that chat.
Yep.
It's about making sure if you asked her who should be present, she would have said, "I would like the following individuals,"
Mhm.
which would have been her children. So I think we have a way to go in healthcare
Yeah.
in terms of promoting that dialogue, particularly as you're with the elderly.
Yeah, no, yeah, great comment. Not for the situations you're describing, but the great comment on saying we still have a way to go. Because I would agree in the sense, and I think in particular when it starts with elderly parents and with some of those things, I have, just by coincidence, several colleague friends that are having parents in hospital recently. Yeah, we've still got a ways to go. And I think particularly with elderly patients, because it does seem to be that the default is they can't make the decision, or we're going to say, "There, dear, don't you worry about it, we'll do this." And you kind of think, well, wait a minute, if I was me in a hospital, you'd be talking to me. So is it our ageism, right? And how do we think about that? Is it some kind of assumption around, because you're older, you'll have a different perspective on healthcare providers? All of those kinds of things that we do need to figure out, how do we have the dialogue and how do we ask? Because sometimes it's unfair if somebody's lying in bed and they're feeling horrible and all of those things, to then say, well, now you have to make all these decisions without the offer of who would you like in the room? Is there a better time? And if that person says, no, I don't want anybody else, or I'm fine, okay, great. But it's making that offer. And I think, unfortunately, in the busyness sometimes of doing the work and sort of, okay, well, I've got this information I need to tell. We forget that it's about that relationship. It becomes about my needs kind of driving where the conversation goes, and not so much about recognizing what the impact of that information is. And I think the other part that you commented on there too is around the advance directive piece and sort of the paramedics. And I think, yeah, we've still got to work out some of the kinks around how we ask people, have you thought about an advance directive? Do you have one? Because a number of people are still hearing that question even as well, it means you're not going to give me any care, or you're telling me I'm dying, right? But you're doing it that kind of way. And so there's a number of communication pieces around that I think sessions like this can help to sort of say, well, no, it's meant to be a different kind of way, so that we can name it when it happens and identify it more often. Yeah, so I don't know. Yeah. Any other questions? Mm-hmm.
I don't need thank you.
Yeah.
I just wonder if you come to a position to like the patient push something and want something and
Yep.
family disagree about this thing and you are just in the middle, you don't know what you do.
Yeah.
Like, you want to go home and you don't want to take care of him and
Yeah.
this kind of conflict. So what do you learn from your perspective as a healthcare leader in an ethics?
Yeah, and I think we're seeing more of some of those kinds of exact questions coming up, whether it's somebody wants to go home but their family's saying we're not able to do it, or well, if we're going to provide care for somebody, they need to go out of province, but they need somebody to go with them. And you're going, well, how do we, as a family, organize to do that? Or some other kinds of ones around, yes, you should have the surgery, no, you shouldn't. All of those kinds of things is that we are getting asked to be involved from an ethics perspective, being asked to be involved to talk about some of those ones. And so I think a lot of the specifics of the situation make a difference to how you might how you might try to work each one through. But fundamentally, it's often trying to draw out the different perspectives and sort of the reasoning behind it and sort of what they're saying. And often I think it's from the caregiver side, especially if you've been caring for somebody at home and then they needed to go into emerge and those kinds of things. Often the caregiver, the person who's been trying to provide that care, is feeling so overwhelmed that it's, well, I just can't do it anymore. And so the question is, if you had different supports, it's sort of, sometimes you can look at what are some of the other options for it. But I also feel, and this is based on some of the experiences with my colleague friends recently, is that we are asking an increasing amount of families to do. And I'm concerned about it. That pressure to discharge, the pressure for people to go home, the pressure to provide community support or be at home as long as possible. And I don't disagree with those things fundamentally, in the sense of, if you can be at home and cared for well, that it's not taking an excessive toll on the family members, that's great, right? And so the more we can do some of those things, I think it does relieve pressures for us in the acute care kind of context. But I am concerned about the acute care sort of pressure putting excessive burdens on families where they go, I have no idea how to care for this person. I don't know what you're asking of me. And so I think sometimes in that role, that's where healthcare providers and some of the health leaders have really played an advocacy role to say, well, we can't discharge this person because we need to find another option. Or we need to think creatively about how do we connect 5 different kinds of community supports to give this family what they need to make it possible. Because sometimes the family might say, I really want to take them home to honor my dad's wish to die at home. But we can't right now. But if we can put some supports in place, it makes it possible to honor the wish and provide that support. And so I think sometimes if we can do those things, that works really well. But I think other times I've definitely seen healthcare providers play a very effective role about advocating for saying, no, this isn't, we need to sort of change how we're thinking or how we're approaching this case, because just because, and sometimes just because the patient wants it, doesn't mean that the family has to accept it. And that is the hardest place to be, because it doesn't feel good from any perspective. But there is that part I had on one of the slides about patient and family-centered care. And I think that's sometimes where if we get too focused on the individual, we forget about the repercussions on the other, on those immediate others for them. And so sometimes it's how do we negotiate that balance between them? Yeah, so does that get at a little bit? Yeah. Yeah, no easy answers. No easy answers with those ones. Yeah, and I can think of some situations that have worked out tremendously well with kind of, I would say, some of the thinking outside the box about how do we put different pieces together for them. And I have seen, I would say, some other families that already had struggles before whatever's facing them at this time. And this was kind of the one that put them over the top. And it's brutal to see. And yet, if you've everybody's individually done everything they can to make it better or make it possible for them. That's one of those ones about the least worst, but it's still awful, right? And I think we need to be able to name that sometimes too, and think about how we support each other in that. Yeah, in that way, yeah.
We'll have time for one more question.
Okay. Oh, there we go. Thanks. Yeah.
You had mentioned, I think it was Gina,
Yeah.
your research
Right, yeah.
of her,
Yeah.
about patients, kind of there being a theme that patients think that it's the doctor's responsibility to bring this up, and they don't want to kind of infringe on their territory.
Yeah.
Do you think, and I guess from your research maybe, is there a disconnect? Does the clinical side view it as the patient's responsibility to bring it up, or? is there alignment in that opinion, or?
Yeah, no, I think it was, because the way that the nephrologist started to describe it, it was almost that catch-22. Well, if nobody's willing to bring it up, then we're never going to get to what really matters for all of us. Because it was pretty clear from her perspective about why we were doing the research that it was important to talk about sort of now and later. And it was important from the patient's perspective to talk about now and later. But they weren't giving each other the opening, right? And so I think for some patients, they feel much more comfortable opening it up or starting to ask some of those questions. And some healthcare providers are really great at picking up what that is or asking the right question that just sort of opens the floodgates. But I think what we saw in the research, and I think we've seen with some other programs too, it's sort of how we structure even the program, or how we structure the care and the kind of the process of the flow of how you come into the hospital, what questions we ask when we take your vitals, and we do those kinds of things. So it kind of sets up a tone of, this is routine, this is where we go, this is what we talk about. And so without anybody really recognizing it, there isn't that space to say, okay, what else is important? So I think that's, for her, was kind of the click moment around, it's actually if you will, kind of a structural issue that's preventing both of us from recognizing that we need to talk differently or we need to create a different space. So they actually, for that particular team and sort of the number of patients they were working with, they actually reallocated time amongst the team to create, for every visit, if the patient wanted, they sort of had the initial advanced care planning conversation with anybody that started with them, so way before dialysis, so anybody that was having kidney problems. They would start that conversation then, give them some materials, and then really have the team the opportunity to come back to it. So it would kind of be offered on a regular basis. So it wasn't forcing the patient to talk about it if they didn't want to talk about it, but it was a regular kind of offer or a regular kind of ask. And that really kind of changed it up for both. And then she built into her appointments with patients, if they had said, yes, I want to talk about it with a social worker or one of the nurses, she had some flexibility built into her schedule so they could spend time talking about it, not trying to cram it in with everything else. And but that was sort of took them really thinking differently about how they deliver. They were still doing the same kind of care, still carrying the same patient load, but just rejigged it to make some of these things the priority. So it sends the signals of, yes, we do want to talk. Yeah, and that was kind of neat. And I've seen a few adjustments with some other programs here based on other kinds of research results, that they've said, oh, well, we're not talking about the things that people really need to talk about. So let's build in telehealth sessions, or let's build in the opportunity to connect remotely if that's something that will help create the space for the conversation. Yeah, so, yeah. Very neat. Yeah, good.
Well, thanks so much, Christy, for that absolutely fantastic lecture.
Great.
I think it's safe to say you've certainly raised our awareness around the sort of ethical challenges and issues that individuals and families face during times of this nature. So thanks so much for that.
You're welcome.
I think it's safe to say also that this conversation isn't going away.
No, it's not.
And we're certainly just getting started here ourselves. The Excellence in Health series plans to continue this conversation in the fall and have Christy come back and be joined by some panelists to speak on that. So please stay tuned for that. And I'm just going to reach down here and pull out keys to a new car.
No.
I wish. But actually I want to pull out, it's an Iceberg Award. It's a very nice sort of thing that you can put on your desk to remind yourself of your time with us. So thank you so much, Christy.
Thank you. Thanks. Yeah, that's great. Goes well with my pictures.